the whole industry that's in this room, frankly, intersects with the market with these gentlemen. So if it wasn't for the patient-doctor relationship, none of what we do would be all that important, frankly. So innovation in the trenches is something that's really interesting. The second thing I'll say very quickly is normally at these conferences we see a cardiologist, we see a spine surgeon, and then pick the third. I wanted to do something different, unique, and talk about diseases that are really prevalent and haven't seen maybe as much innovation. I will say that ophthalmology as one of them has really in the last 5 to 10 years increased dramatically. GI has a lot of innovation potential and some interesting issues inside of it. And then pain management is just an absolutely burgeoning area of healthcare. So without further ado, the way that we're going to do it is we're going to let them tell you a little about themselves, their practices, and what they think of innovation. Bob, you want to go first?
Hi, thanks for having me here today. I appreciate the invitation. I'm Bob Ganz. I am a gastroenterologist, practicing gastroenterologist. I've been in the Twin Cities for about 20 years or so. I have a full-time practice focusing mainly on diseases of the esophagus, reflux, Barrett's esophagus, early-stage adenocarcinoma of the esophagus. I also do some inventing and some device development. I invented the Barrex Halo device, if you're familiar with that device, and started the Barrex company with 2 other co-founders. I've done a bunch of other developing type stuff in GI, but the Barrex is the device we've taken the furthest, the Halo device. I also do some foundation work for the GI societies and have a faculty appointment at the University of Minnesota.
Eugene de Juan, I'm a professor at University of California, San Francisco, ophthalmologist. My background has been in universities since I trained at Hopkins. I was 9 years at Duke, went back to Johns Hopkins, headed vitreoretinal surgery there, then went to University of Southern California. 5 years, established an institute called the Doheny Retina Institute, and then for the past 5 years, I've been at UCSF and Foresight Labs, which is an incubator to develop new technologies in ophthalmology. Have, just spent my whole life in universities and developing stuff, working with companies and trying to solve the problems.
And I'm Dr. Dave Schultz, and I'm an anesthesiologist by background. I now do full-time interventional pain management. I'm founder and medical director for a pain clinic practice in the Twin Cities, and we have pain clinics and surgery centers around the metro. Basically, I implant pain-controlled devices. Usually they're Medtronic, but sometimes advanced neuromodulation systems, St. Jude. Neurostimulators and pumps. So I implant probably 80 or so stimulators a year and about the same number of intrathecal infusion pumps. And then in addition, I own a research company that does sponsored research for Pfizer, Medtronic, St. Jude, and other sponsors. And so we're doing various protocols right now. We probably have about 10 or 12 studies that we're collecting data for. And I'm the PI on those studies.
Number one, and we'll start with Dr. Schultz. Do you have any unmet needs in your practice?
Many unmet needs. And just to give an example, we do a lot of end-stage pain management where the patients are quite ill. They're also in severe pain. Some of them are hospitalized for prolonged periods. We'd love to be able to keep them at home, and I'd also love to be able to use an epidural infusion system to manage their pain. If you think about an epidural, a labor epidural, for instance, can block pain in the abdomen selectively for labor, for instance, and so it's very powerful. We can even create surgical anesthesia with this. But to keep the patient in the hospital for weeks with an epidural is extremely expensive. So if there were some way of having this technology to be used in the home setting, I think that would be great. It would revolutionize our whole pain approach to some of these end-stage problems.
And we'll come back to some more of that. Dr. de Juan, you have any unmet needs in your practice?
Yeah, none in my practice, but I've noticed a lot in everybody else's.
and Dr. Ganz, do you guys have any unmet needs?
I'm in GI. It's an interesting field. Food goes in, poop comes out, and if it doesn't, you're in big trouble.
Enough said. All right, next question.
A multitude.
Yeah, we're trying to
of
keep this short and sweet. Sweet being the operative term for you, Dr. Ganz. Is your specialty generally aggressive or conservative with innovation, Dr. de Juan?
Ophthalmology is really both. It's one of those few specialties that's medicine, surgery, but we have our accountants and as well as our innovators. Yeah.
Dr. Ganz.
In GI, I would say we are conservative to the point of being pusillanimous. It's a very data-driven field. The procedures are generally very safe, easy to do, no complications. So anything you do that introduces any risk is not well accepted in the field. So it's a very conservative.
Conservative, all right. Dr. Schultz?
And pain management, interventional pain management specifically, is really the opposite. It's a frontier. It's really not well defined what the specialty is. In the past, everybody was dabbling in pain and no one was really owning it. But over the past 10 years, it's become a bona fide medical specialty with CMS recognition. And I think it's evolving to become a GI or cardiology type specialty with its own residency and so on. But in the meantime, there's a lot of cowboy mentality in pain management. There's also a lot of patient need for pain relief. So those two things together make, I think, interventional pain more aggressive rather than less.
All right. To the next topic very quickly. What do your patients currently have on their mind? So you see it, I'm sure it refreshes sort of every time. What's the current thinking of your patients when they come to your office? Bob, you get to go first.
You know, GI is funny. It's a funny field. It's different than most fields. It's really a lifestyle field. Our patients, for the most part, don't die. They're not that sick. We don't deal with death and dying very much in GI. So it's lifestyle. It's things like heartburn, gas, constipation, just not feeling well. And there's a lot of patients with a lot of GI diseases that are lifestyle affecting. They can't eat what they want. They can't sleep the way they want. They can't go to the bathroom the way they want. So that's the kind of patient that we see. Now, having said that, there's huge room for improving those symptoms. And we do have, obviously, very sick and serious patients. But for the most part, we're a lifestyle specialty with all the kinds of issues that you would think of when you go home and eat dinner with your wife and your family or husband and family, belching, farting, that kind of stuff.
Dr. Schultz, what are the patients that you've seen have on their mind?
Well, in 2 words, pain relief is what they want. But opiates are really a big issue in the pain clinic, and many people come to us wanting pain relief with narcotic pain pills. And we have to separate out the legitimate patients who are taking these medicines from those who are drug seeking. And we have an interventional focus, so we try to provide alternatives to narcotic pain relievers for chronic and persistent pain. But most people, the ones who have severe pain and also have addiction issues are the most difficult to manage, and they're very demanding, and they want pain relief, and they want it through narcotic analgesics.
Dr. de Juan, what do your patients have on their mind?
Yeah, I'm just glad I'm not
Yeah.
most folks. I'm a retina physician, so I take care of patients with macular degeneration, diabetic retinopathy, retinitis pigmentosa, or retinal degeneration. And, most of the patients that I see with those diseases are afraid they're going to go blind, and they're scared. And, we have a whole field of what I call retinal psychiatry. The biggest innovator would be a tissue box dispenser that could do it really quick, because so much of it is emotionally geared if you think you're going to go blind. So it's an important field. It's very valued, and luckily we can do things.
Yeah. So in the future, do you think that your patients care enough about innovation or new technologies that they will either pay for it or pay for part of it?
Most of my patients probably don't have the financial wherewithal to pay for certainly the high-tech pain relief available. For instance, a spinal cord stimulator or a pump, we're talking $20,000, $30,000 worth of expense. So they just, even if they wanted to, even well-to-do people wouldn't be able to pay for that. But the general feeling is if it's not covered by insurance, they don't want it. in the pain clinic.
So they'll deal with massive pain instead of having to pay for it themselves.
They'll take pain medicines and not really care about much else.
Right.
Because pain medicines are relatively lower cost compared to high-tech devices.
Okay, Dr. de Juan.
You know, if you're blind or you're afraid of going blind, or you'd pay for anything.
Yeah.
If you're really frustrated with your quality of life, and vision just impacts quality of life so much, you know, I think ophthalmology has really led a lot of the fields we do. Roughly close to 1 million LASIK procedures that are full patient pay. And the cataract field, we've gotten a reading from Medicare that says, okay, you want a standard cataract, fine, but if you want one of these special lenses, you can upcharge for the quality of life component of that field. So I think there's a lot of patient pay in ophthalmology.
Yeah. And how about GI?
You know, it's really interesting, John, when you think about medicine. Medicine is the least retail business in America. There's no retail component to what I do. It's very interesting. I'll prescribe fiber, but I don't sell fiber in my office. I'll prescribe probiotics, but I don't sell probiotics in my office. I'll prescribe medication, but I don't prescribe it. I'll put people on lifestyle diets, but I don't, you know, do Weight Watchers out of my office. You know, it's very interesting to think how little retail we do and the tremendous potential for doing retail type stuff in a medical office. The people who really do it are the dermatologists, but they're the only ones. So there's a huge opportunity there.
Yeah.
In terms of will patients pay money for diseases, the answer is it depends. Depends on what it is. If it's obesity, and I have an endoscopic endoluminal device that'll treat obesity, they'll pay a lot of money to treat their obesity, a lot of money. If it's a disease that they have, reflux or Barrett's or something like that, I think they will pay. But here's the problem that we have. The problem is I have to give them a price. It's got to be a single price. I have to say to them, I'll treat your reflux. It'll cost you $5 grand or 10 grand or 15 grand, whatever it is. It's got to be a price, and it's got to be a fixed price. Can't be any more, can't be any less. And that's very hard to do in medicine. We don't have the capability to do that. Because I might treat them once, it may partially work, then they're coming back, they may still stay on meds. Or I ablate their Barrett's, maybe I don't get all of it, they have to come back for a second procedure. That's the problem. I have to create a system where I can give them a price. The price has to be transparent, and the price has to be at the point of purchase. If I do that, then I can sell patients services. And the people who do that are the ophthalmologists with LASIK and the plastic surgeons. It's a transparent price. It's there when you walk in the door. Everybody knows what the price is. It stays the same. It doesn't change. We don't have that capability in medicine, but I think it's going to change. And until we have that, we're not going to be able to do it.
So I've always liked this. There are certain terms of endearment that have come out in the last year or so, and I'm going to read them, and then you can respond to any one of these terms of endearment that you so choose. So number 1, reform. Number 2, fraud and abuse. Number 3, FDA. Regulatory anything. CMS, reimbursement, death panels, capitalism, or tort reform. Every one of these completely encompasses what you do on a daily basis. You know, the world's your oyster right now. What would you like to talk about, Dr. Schultz?
Well, I'll take the first one, reform. I think we all realize that reform is here, and I think we're witnessing the transformation of American medicine that will happen over the next perhaps 5 years. But in the essence of it is that 49 million new people have been added to the ranks of the insured, yet there really is no cost reduction built into the system. So the question in everybody's minds is how are they going to take care of that many more people and keep costs low? And I think they're going to do it through evidence-based medicine. Evidence-based medicine has been around for a long time, but now it's going to be used as a gauge of what is covered and what isn't. And I think the payers and certain groups of doctors are going to become much more rigid and hard-nosed about saying there's no evidence for this, we're not going to allow it to be covered. We just went through this battle in Minnesota on spinal cord stimulation, which has been around 25 years, and there's actually very good data to support it, yet people were attacking that data as not good enough. And there was a recommendation by some doctors on this panel to say, let's not cover spinal cord stimulation. We prevailed by going up there and arguing data, but it was really a science argument. It wasn't like, I think it's good and you don't. It's what does the data show?
I think now the game has changed. So it's not just solving a medical problem. It's solving a medical problem in a timely way for the investment. It's solving it in an economically sound way to protect the healthcare system. It's, it's making it, so we're going to have to be smarter and smarter and smarter, and our innovations are going to have to be more direct and more simple, not more complex, I don't think. And so and I think we can do that. I spent a lot of time trying to figure out a simple way to solve a serious problem. And that's where, the more innovation comes in. I think there's some real issues. I've been in the university my whole life. I live in that environment. We're not all, super conservative. We are also a lot of the idea people. And so we have to drive that as a valued part of what we do. So it is, I think, conflicts of interest. I've been in a lot of universities and they say, well, now that's a really good idea, but you can't work on it, because you have an inherent conflict of interest. And it's just, how do we deal with that going forward?
Yeah. Bob?
So I've got a bunch of them, but I'll talk about reform, healthcare reform. So in the old days, you had a device, it looked pretty good, you had some safety data, you had some early clinical data, and you went to Blue Cross Blue Shield or Medica or United Health Group or Aetna, and they were in the business of pleasing doctors and patients. So the device looked pretty good. They would go ahead and pay for it. And it didn't actually take that much to get them to pay for it. But now things have changed. They can't deny people with pre-existing conditions. They have to keep kids on their health rolls now until age 26. They have to invest 85% of their money into a medical loss ratio. So they can't hold the line on patient care. So what they're going to do is they're going to hold the line on new tech. So basically, they're not going to pay for new tech. And we've noticed that in our devices. If you don't have level 1 evidence, randomized controlled trials, make your endpoints. If you don't have level 1 evidence, they're not going to pay for it, period. Period. Even if you have level 1 evidence, randomized controlled trial, multi-center, make your endpoints, they're not going to pay for it unless there's also a society guideline that supports it. What's the bottom line on that? They force you to do a randomized controlled trial. It takes years to do. Once the trial's done, they force you to get a society guideline. That takes another year or two. So they've pushed that payment for that new tech out 4 to 5 years. That's the game they're playing now. So when you fund a device, you have to factor that in. It's not going to be just a single center series of 30 or 50 patients. It's going to be a randomized controlled trial. The FDA's in on that game too, right? They're going to change the 510K path. They're going to demand clinicals. Nobody knows what that means, but I guarantee you the clinicals will probably be a randomized controlled trial. So it'll look essentially the same as a PMA, I think. So that's the problem. You can still do tech. It's going to be a lot more expensive to get it out there. It's going to take a lot more time. You have to fund yourself for that, and that's a big problem.
We touched on this a little bit, but I'm really interested in your thoughts. So as venture capitalists and as CEOs, our businesses have become very complex. The pathways are not quite as straight and narrow, and they're actually variable. So should we be thinking about innovation as a very complex thing going forward, or should we be thinking about innovation simply as cost reduction? What would be your 2 cents on that?
The FDA in the past has not considered structurally any cost issues, but I was just at a meeting at CMS about a therapy that would drastically change deliver a lot of value to the healthcare system. And so I think that one thing that we'll see in the future is that establishing essentially parity and having a lower cost being a useful endpoint, where before it was only clinical endpoints that people judged.
So, Dr. Schultz, it's very unique in pain management. Is it cost or morbidity? Which is the more important, do you think?
I think cost is going to be the overriding concern with U.S. healthcare in the next decade, because, as I said, they have all these new people who are insured, and the system is already going bankrupt. And now it's going to be even more pushed that direction, and they just have to reduce costs. So if your technology doesn't reduce costs, I just think it's going to get sidetracked.
I think when they talk about quality, they really mean cost. When they talk about cost, they really mean cost. And when they talk about outcomes, they really mean cost. I think it's all cost. And I think the insurance companies view physicians as always having all these new tools, and the new tools, in their mind, always increases cost, because it's, in their mind, you do the new thing and the old thing until you sort it all out. And I think they're trying to hold the line on new stuff. You know, the old expression is a fool with a tool is still a fool. And, you know, I think there's a lot of foolishness in how we introduce new tech, physicians I'm talking about, and societies, how we introduce new tech. And to a large extent, it's been because the studies haven't been well done to really tell us how to do it. But these things are complicated. It's not really a clean break between old and new. It's usually additive or iterative or a variation on a theme. And so, to a large extent, new stuff increases costs. They're trying to hold the line.
So it brings up an interesting point from a non-scientist standpoint. And I really like your opinions on this, because it seems like we're blowing down the path that everything has to be scientifically proven. And I think that it's potential that physicians, through experience, garner great judgment, and that not everybody fits inside the bell curve very well. How do you feel about the future? Do you think you're going to be able to use clinical judgment to some extent, and to what extent do you think you can use it? Or how much of it is going to be guideline-based, protocol-based? I think Dr. Nelson maybe mentioned that last night. So Dr. Schultz, why don't you go first?
I mean, that's the battle that's raging right now. Medicine is an art and a science. In the 80s and 90s, the art prevailed. It was doctor-patient relationship was king. If I felt something was a good thing, we'd try it. If it improved quality of life 20%, you know, great, even if it cost thousands of dollars. But going forward, I think that cost reduction is going to prevail, and they're going to use science to prevent technologies from coming on board to reduce costs. And so I just don't think that I will be able to say, hey, I think it's going to work well, let's try it. Instead, the payers will determine, is there randomized controlled data to pay for it.
Gene?
We have to depend on true knowledge to go forward. The art is wonderful, and how we apply it won't change. But we really have to have that base, and that depends on how we get the data, and how we need to be data driven. But and so I don't see that. I think that'll only increase in our innovation and intuitiveness, and an importance is how do we design those trials so that they can be well interpreted by our colleagues. And I think that what we've done is design trials to get through the regulatory process, the easiest, the quickest, and not really to change medicine. And I think we're suffering a little bit from that.
Physicians left to their own devices, 50 doctors will do something 50 different ways. We're archaic, obsolete, really, when it comes to treating patients in many ways. In my practice, we're all university trained, all board certified gastroenterologists. You come in with diarrhea, gas, irritable bowel syndrome, you get 50 different evaluations. I'll tell you one story that'll illustrate why we need checklists in medicine. A buddy of mine had a peripheral neuropathy. He's a CEO of a company, startup company. Bad peripheral neuropathy, kept getting worse and worse and worse. Couldn't feel his fingers, couldn't feel his toes, couldn't hold a pen, couldn't type on a keyboard. Saw a neurologist in Minneapolis, mega workup, many thousands of dollars, nothing. Went down to Mayo, mega workup, many thousands of dollars, nothing. He was on a trip with a physician, First thing physician said to him was, "What meds are you on?" He said the meds. He said, "Why don't you stop your meds?" It turned out he was on a medication, simvastatin, that causes peripheral neuropathy. His peripheral neuropathy went away the next day. That was a $100,000 workup because nobody bothered to have a checklist to stop his meds or see what meds he was on. That happens every day in American healthcare. Clinical judgment, to use the vernacular, sucks. We need guidelines, we need protocols, we need checklists. I'm a huge fan of that. And I think it'll be dramatically important in lowering costs in American healthcare.
Will politics drive guidelines, or will real data drive guidelines? And then finally, if you look at the bolus of data in any particular area, I would think it could be fairly confusing. So how do you bring all that together really to affect this in an impartial way for the patients, or the best for the patients?
The answer is data will drive it and politics will drive it. Because at the end of the day, you have somebody sitting around a table who's going to draft the guideline or the protocol, and their bias will come into play. But you're going to have a starting point. It's not going to be an ending point. It's going to be a starting point. And data turns over all the time. So our knowledge base turns over every 18 to 24 months. So protocols have to be constantly upgraded, constantly massaged, constantly looked at. It's not an easy thing to do. It's an expensive thing, but it's a valuable thing. And so, yeah, there'll be some politics involved, unfortunately. But it'll be better than what we're doing now, I think.
I've seen a lot of private practices start to be difficult, and so they have been selling them to hospitals or reintegrating into hospitals. How long and what percentage of physicians will be on salary in kind of what time frame? Just, you know.
Yeah, and if you saw the Wall Street Journal the other day, for the first time in U.S. history, first time in history, there are more more physician practices that are owned than practices that are independent. In 2004, 80% of practices in America were independent. Today, less than 50% are. We're entering into the era of the mega group, or the mega integrated group. That's primary care and specialty care. In GI, it's happening like lightning. All the GI groups around the country are being integrated, merged, bought up. So you're not going to have small practices in America in the next 5 years.
Till five years, and when they're integrated, it will be salary driven, not any other. Or do you think there'll still be some?
No, not necessarily. It could be production based.
Okay.
It depends on how it's done, but they won't be independent.
Yeah. In California, we have Kaiser, and if I look at where the young physicians are going in ophthalmology, very often they will go to Kaiser. They'll have a 4-day work week, 35 hours. You know, they'll have a salary. They'll be on a salary. It's a very attractive place to work now for the young doctors, and so I think you're going to see it a lot more.
David?
Yeah, I think that's a trend that's going to continue, and it's a little bit unfortunate in my opinion. I think it's a little bit of the dumbing down of American medicine to work a 35-hour week and not really be motivated to do much beyond that. But I'm afraid that might be where we're going.